This is Suicide Prevention Module 2. In this module, I'll discuss suicide risk assessment, including environmental factors, assist you in understanding the protective factors that may play a role in reducing suicides, identify safety plans both for receiving facilities and at discharge, and discuss the resources in-state and nationally regarding prevention and recovery from suicide attempts. A suicide assessment must go further than only taking the person's word that they're not suicidal. Always solicit family input and consider history.
But Abby's mother was stunned when the school told her Abby was not invited to either event. And Julie Bartell says the school told her security would keep them out if they tried to come. The Milton Hershey School told CNN, "We must balance the goal of keeping a child at the school with the absolute mandate to ensure the safety of all children entrusted to our care." In other words, the school believed Abby could be a danger to other students. Abby's stepmother told the 14-year-old the bad news.
And I said, the school does not want you to attend graduation because you've been in the hospital.
Abby was devastated. Her mother called the school.
Abby has been through so much. This will be devastating to her. I cannot believe you are doing this. I said, are you a child care professional at all? I said, what are you, a bunch of morons?
The school did not budge. 8 days after the graduation she wasn't allowed to go to, Abby's step-grandfather was in the house and called Abby's name. He did not get a response. He walked up to her room and saw her in the closet.
I said, "Oh my God, Abby, what did you do?" And I was kind of waiting for an answer, but I knew it wasn't going to come.
Abby was dead. She had hanged herself on the clothing rod in her closet.
Asking direct questions about suicide does not increase the likelihood of suicide with individuals who are at risk. Evidence suggests that asking direct questions about an individual's suicidal intent can positively impact a person in crisis, provided such questions are asked in a compassionate and empathetic manner. If the person at risk of suicide offers indirect statements suggesting suicidality, such as "I'm a burden" or "I've had enough," be sure to explore these thoughts with direct follow-up questions about the suicidal intent. As a reminder, those two components that need to be in place for someone to be Baker acted are the clinical component, which means that impairment, mental or emotional, that exercises control over one's actions or ability to perceive and understand reality. Also the functional component, which means that the individual substantially is unable to meet the ordinary demands of living. The most common evidence type upon which involuntary examination initiations were based was harm only at 63.60%, with other exams initiated based on harm and self-neglect or self-neglect only or not reported. Over half of the involuntary examinations, or 53.92%, were based on harm to self only. It is useful to evaluate suicidal thoughts, plans, and behaviors through direct questions about current and past suicidal thoughts and actions. Important questions may include: are you thinking of killing yourself? Are you feeling hopeless about the present or the future? Have you had thoughts about taking your own life? Sensitivity is very important. An evaluator may use an introductory statement such as, "Sometimes when people feel sad or depressed or have problems in their lives, they think about suicide. Have you ever thought about suicide?" It is often vital to obtain background information about an individual at risk of suicide through collateral sources such as a person's friend, family, or caregiver, or even coworkers. There is no one-size-fits-all suicide risk assessment. The unique situation of each person needs to be taken into consideration. It's critical that the professional performing the individualized risk assessment have as much information as possible about that individual. While assessment instruments are valuable in detecting potential risk factors, the face-to-face clinician interviewing the individual should be at the core of any comprehensive assessment protocol. Data collection from assessment instruments supplement but do not supersede that clinical judgment.
I pose these questions to you. What would you do if your family member, friend, or loved one was suicidal? What would you say? Would you know what to say? In my experience, it's not just the talking that you do, but the listening. Listen to understand. Don't argue, blame, or tell the person you know how they feel, because you probably don't. By just being there, you may just be the turning point that they need.
A comprehensive approach to suicide risk management should include a psychological test, reliable and valid suicide risk assessment measures, comprehensive psychodiagnostic evaluation, a complete biopsychosocial history, documentation of suicidal risk, and ongoing assessment of suicide risk throughout treatment and the assessment process. Note that children often do not formulate detailed self-harm plans like adults, yet certainly they still may be at risk. Also, children tend to be more impulsive, as we've talked about in our child development sequence on minors, and any risk assessment should take this factor into account.
Like, I give them plenty of hints. I used to walk into their room in the middle of the night saying, I'm scared, I don't want to live, I can't take this anymore, I don't like my life, I'm such a terrible person. And of course that just makes you depressed. So I had decided, like, life wasn't worth living. When I was 16, I tried to kill myself. I took a bottle of my medication, clomipramine, and I just kept swallowing the pills. And I really didn't want to die. I just wanted to be normal.
As a result of a grant from NIMH, Gregory George created a systematic examination of the psychometric properties of measures of suicidal ideation and behavior for younger and older adults. He examined instruments which assessed for or utilized suicide ideation and behavior, lethality of suicide attempts, brief screening measures, hopelessness, reasons for living, and attitudes and knowledge concerning suicide. Although some of these measures do not directly assess suicidal behavior, such as the measures concerning hopelessness or reason for living, these variables have been closely associated with suicide, as we've talked about with depression, and are potentially modifiable with treatment. The instruments reviewed are listed here. Regular and stringent precautions must be implemented to minimize risk of self-harm for all individuals that are admitted to receiving facilities. Routine safety checks allow staff to confirm a person's whereabouts and current emotional and behavioral status, including their emotional stress, if there's any sudden change in mood, or extreme restlessness. It is vital to note that protective factors may not eliminate imminent threat of death by suicide. Once admitted to a Baker Act facility, it is critical to evaluate all individuals demonstrating suicidal behaviors or making statements as such. Threat levels include minimal/low threat. That's when a person has thoughts of death but states no plan or intent to harm themselves. These persons have modifiable risks and strong protective factors. Second, an increased or moderate risk. These individuals have two, but not three, of the following: suicide plan, intent, or means. The person may have multiple risk factors and few protective factors. And third is the imminent or high risk. This person has a plan, intent, and the means to harm themselves in the immediate future. They lack a sufficient protective factors to keep themselves safe. The person may have a psychiatric diagnosis with severe symptoms and or have experienced an acute precipitating event. Self-harm threat level is not static and may change over time as stressors fluctuate. Based on the determined suicide risk for each individual within a facility and according to the CF Operating Procedure Form 155-26, staff may devise a specific observation plan. The plan authorization must include the date and time the specialized therapeutic observation is implemented, and then specify the type of observation. I'll talk about those on the next slide. The purpose of the observation, duration, and or under what conditions the authorized observation can be terminated. The levels of observation range from routine observation to 2-to-1 observation. The first level, routine observation, consists of visual observation, which is not the result of a special written order that would be in a resident's medical record, and it involves at least 30 minutes time checks completed by direct care staff in settings which residents generally occupy, such as bedrooms, wards, restrooms, dining room, activity room, etc. Supervisors will ensure that the staff members are vigilant and aware of each resident's whereabouts and status. At the end of the time frame, each facility will maintain a residential area coverage sheet on a daily basis. Second level is that close observation, or CO. This level requires that staff monitor a person's condition, location, and or behavior every 15 minutes. The person is not continually watched, and this procedure should be used for issues of a less serious nature where routine observation would not be frequent enough and one-on-one observation would be too intense. Close observation will occur in settings where residents generally occupy, such as bedrooms, wards, restrooms, dining areas, etc. But this one consists of that visual observation, which is a result of a special written order in that resident's medical record. And it will ensure that the staff members are vigilant and aware of each resident's whereabouts and status. This level of observation must be reviewed and renewed at least every 7 days and include a face-to-face exam by the clinician. The next level, group observation, or GO, requires the staff member to remain within visual contact and close proximity of up to 3 designated residents in order for the physical, medical, emotional, and security needs of the resident to be met. The assigned staff maintains visual contact with the assigned residents at all times. Should a resident need to separate from the group observation for medical care or to go to the bathroom, additional staff assistance would be called in. Documentation of behavior, activity, and location is required every 15 minutes. Authorization for this group observation is by clinical order, and the level of observation must be reviewed and renewed again at least every 7 days with that face-to-face examination. Residents who have been determined by a clinician to be at risk of suicide would not be appropriate for this group observation. The next level, one-on-one, one-to-one observation. This level of observation requires one staff member to maintain uninterrupted visual contact of a resident while remaining within arm's length at all times. If it's determined by the clinician that arm's length creates a danger to the staff or is not therapeutic to the resident, then the clinician may write an order indicating a change of that. Staff assigned this coverage cannot be assigned to more than one resident at a time, and the documentation must be every 15 minutes. Authorization for this one-to-one observation is by the clinician's order and must be reviewed at least every 24 hours and include a face-to-face examination by the clinician. That final level, the most intense, is 2-to-1 observation, and this level requires two staff members to maintain uninterrupted visual contact of a resident while remaining within arm's length at all times, unless of course it's determined by the clinician that that arm's length is not in the best interest of staff or the resident. Staff that are assigned to this coverage are not to be having to look at any other resident at this time. 2-to-1 observation requires documentation at least every 15 minutes, and the authorization for this 2-to-1 observation is from a clinician and must be reviewed at least every 24 hours, including that face-to-face examination with the clinician. Note that closed-circuit television monitoring does not prevent suicide. It only identifies a suicide attempt in progress. That CCTV monitoring should only supplement physical observation by staff. The cameras should be enclosed in a tamper-proof box that does not contain any anchor point. It should be placed in a high corner location of the person's room, and all edges around the housing should be caulked or grouted. Rooms should be painted in pastel colors to allow for better visibility of the camera and should provide a clear and unobstructed view of the entire room's interior, including all four corners. Although it's seemingly impossible to create a 100% suicide-proof environment within every room in every facility, it is feasible to ensure all rooms housing potentially suicidal persons are free of obvious protrusions. To ensure that individuals on suicide precautions are housed in quote, suicide-resistant, unquote, rooms, facilities are strongly encouraged to implement the following architectural and environmental recommendations in this PDF as shown. Florida's DCF Operating Procedure CFOP 155-41 indicates facilities must implement the following measures in order to prevent self-injury or death by suicide. Use plastic hangers without small hooks. Monitor the linen supply. Use paper rather than plastic bags when possible. Restrict a person's access to cleaning supplies, medications, and chemicals. Phones must have short cords and remain visible to staff. All shower rods and other fixtures like towel bars, window curtain fixtures, etc., must be breakaway, that is, unable to bear the weight of a human. Tape, rather than tacks or staples, should be used to post information. Continuing the CFOP 155-41, secure television cabinets and other furniture to the walls so they cannot be tipped over. Remove any extension cords. Use plastic mirrors in at-risk areas. Remove extension cords and loose or dangling cords. Restrict resident access to high places. Design ceilings without removable parts. If this is not possible, then check ceilings for residents' access to concealed woodwork, piping, or ductwork. Check for hidden implements in low drop ceilings. Remove broken furniture parts. Ensure that all screws are tight and recessed. Monitor access to razors or batteries. Restrict access to cleaning supplies. If necessary, move the individual to a room without windows.
As part of continuous quality improvement, each facility should encourage direct care staff to make recommendations to the Environmental Quality Control Program Coordinator regarding individual safety.
In addition to reducing risk factors, utilizing or enhancing protective factors is critically important in suicide prevention. Protective factors are believed to reduce the likelihood that someone will harm or kill themselves. As with risk factors, protective factors can be environmental, biopsychosocial, or sociocultural in nature, and they vary according to age, gender, ethnicity, and religion. Protective factors that may reduce the likelihood of someone committing suicide include effective and ongoing clinical care, access to clinical intervention and support, cultural or religious beliefs that discourage suicide, family and community support, and restricted access to lethal methods of suicide. Because suicide ideation can reoccur, so prevention efforts should be ongoing. Risk and protective factors associated with suicide, especially mentally ill and substance abuse disorders, form the conceptual framework for the prevention recommendations in the National Strategy for Suicide Prevention. We should continue efforts to enhance protective factors while being vigilant for warning signs and risk factors.
Tell me why you thought about taking your life.
One day, I just realized that I wasn't having fun. Life wasn't, like everyone always said life is fun, they're out doing stuff. I rather had just been dead. Because, my family's really religious, and, I'd rather be in heaven being happy than living here. I felt like this was hell itself already.
Understanding the cultural context of suicidal behavior is essential for effective prevention. Culture is defined as a belief system and value orientation that influences customs, norms, practices, and social institutions. Culture profoundly influences how people think about suicide, death, and mental illness, how they display emotions or distress, and how they ask for or accept help. Additionally, culture is complex. The cultures of groups sharing common histories and or heritages are not adequately described by categorizations such as Hispanic, American Indian, Alaskan Native, disabled, rural, Southern, or LGBT, nor is culture static. Culture changes over time, and culture impacts various aspects of suicide and suicide prevention. including the following: protective factors. For example, family support may be a strong protective factor in immigrant families, but such protection can be weakened as families become Americanized and as young people grow more independent. The precipitants of suicidal behavior. Culture influences how people respond to events that escalate risk and trigger suicide attempts. In cultures in which peers' influence is strong, for example, the suicide of a friend or a schoolmate may provoke a copycat suicide. This may not happen in cultures where family influence is stronger than peer influence. In those cultures, a suicide attempt might be triggered if a vulnerable person fails to meet family expectations, say in academic achievement. The understanding and expression of the warning signs of suicide. Cultural influences how people display or refrain from displaying emotional distress. Some cultures may promote a stoicism that makes seeing warning signs difficult. People from other cultures may be reluctant to talk about their problems, rather, they express them through behavior or their demeanor. Help seeking behaviors. Culture plays a large role in determining who, if anyone, folks turn to for emotional support. People from some cultures may prefer to consult family members or religious leaders rather than mental health professionals or other, quote, outsiders, unquote. Other cultures may value self-reliance and regard any help seeking, even within a family, as a weakness. Trust. From groups with histories of victimization, oppression, sectarian violence, or other forms of trauma, there may be fear from people that represent authority, including school, police, or mental health professionals, or from cultural groups other than their own. Suicidal behaviors arise from a complex interaction between psychological, biological, genetic, sociological, and economic factors. Due to the numerous variables, including those that we've talked about with risk and protective factors impacting suicide risk, accurate prediction of future suicidal behavior is difficult.
A person with suicidal ideations and has been diagnosed with depression is most likely to actually attempt suicide. They may not attempt suicide while feeling depressed. However, once feeling better or gaining a little more energy, they are likely to follow through with suicidal ideations. Individuals admitted to a psychiatric hospital are at increased risk for dying by suicide in the year immediately following discharge, with a significant percent occurring in the first few weeks post-discharge. It is vital to connect discharged individuals with needed services and supports, and elicit family members to restrict access to lethal means, such as remove guns from the home and monitor medications.
A safety plan is a written document that's formulated by the person and the therapist or provider together. It is a detailed roadmap for keeping the person safe. The person promises that instead of acting on suicidal thoughts, that they'll allow the steps in the individualized safety plan to occur. Such planning requires the individual at risk to anticipate likely preceptors of elevated risk, such as deterioration of personal relationships or an increase in symptoms like depression, insomnia, or hallucination. The safety plan gives the individual specific, concrete, non-suicidal action steps. Safety plans are only one tool to help individuals at risk remain safe. A no harm contract alone is not an adequate safeguard. There's no empirical evidence supporting their clinical efficacy in preventing suicide. No-harm contracts typically ask the person to pledge not to harm themselves without offering safe alternative coping behaviors. Facilities can utilize two types of safety plans. The first addresses the individual's stay in the facility, and the second addresses suicide risk after discharge. Facility staff are encouraged to complete a personal safety plan, Form CFMH 3124, with individuals being served during their initial assessment. This document specifies personal stressors, relaxation techniques, and preferences regarding crisis management interventions. It's intended to keep the individuals served and the staff safe from a crisis that might arise. After admission to a facility and following stabilization, the next major step in the treatment process is discharge into the community. This includes referrals for follow-up therapeutic services. The first months post-discharge are critical for the individual at risk for self-harm. A safety plan, similar to the one that's used during a facility stay, is a useful tool if the person experiences another crisis following hospitalization. Supportive friends and family should be encouraged to participate in creating and maintaining the post-discharge safety plan. A key element of this involvement is ensuring the at-risk individual's home environment is a safe place. Safety plan steps that family members or friends can take to help include removing any lethal weapons like guns or knives from the home and the car, restrict access to large amounts of medication, help the individual identify a reason for living, help them make a plan for life, ask that person what they would tell a close friend that's contemplating suicide and have them write down the answer and follow their own advice. Advise the individual to avoid drugs and alcohols, or at least encourage moderation in drinking to ease that pain. Follow your instincts. If you believe that the person may act on self-harm impulses, arrange for someone to stay with them. Learn to recognize those warning signs that we talked about in Module 1, and suggest the person keep a daily journal of their thoughts and feelings as an emotional outlet and a means of monitoring any escalating distress. Firearms are the most commonly used method of suicide among males, and poisoning is the most common method of suicide for females. Is your home suicide-proof?
Along with post-discharge mental health services, restricting access to lethal means and situations is critical for keeping an individual at risk safe. In addition to firearm access, which increases a person's risk of dying by suicide, access to drugs, both illegal and prescribed, high locations, and toxic domestic gases are also documented risk factors.
Family involvement is vital in maintaining a person's safety. Family members can help an individual at risk of suicide by restricting access to lethal means of injury and suicide. They can inform staff about the person's cultural or religious beliefs that discourage suicide. They can assist with follow-up mental health care appointments for the individual, such as transporting or setting those appointments. Family members can be valuable support systems for the individual and assist with assessing the available resources. Preventing suicide and suicidal behavior requires the support and contributions of many partners: federal agencies, state and local health departments, nonprofit organizations, academic institutions, international agencies, and private industry. Partners help in a variety of ways, including collecting data about suicide, learning about risk factors, developing strategies for prevention, and ensuring that effective preventative approaches reach those in need.
Just that type of negative thinking. I went to the Oxford Centre for Brain Research, where they have been examining activity in the brains of depressed people. Their work centres on the amygdala, a tiny area that's like the computer hub of the brain. Just like we saw with the hippocampus, the amygdala behaves differently in depressed people.
So this area here is the amygdala that we're interested in looking at.
Just right in the centre there? Research scientist Catherine Harmer took a sample of depressed people and showed them negative images as she was scanning their brain. Her results are fascinating. They show that depressed people's brains exaggerate negative images.
So these are all slices in the brain taken at different angles, showing the response or the difference in response in the amygdala in people who are depressed and people who aren't depressed. And so what the activity level that you can see in red here is the difference between those two groups, the statistical difference.
Yeah. In other words, the science clearly shows that people with depression lose perspective, and part of their brain is much more sensitive to negativity. But there is hope. They also found the amygdala does respond positively to treatment, like antidepressants or talking therapies.
For additional information about the National Strategy for Suicide Prevention, see the URLs listed on this slide. Suicide ranks as the 9th leading cause of death in the state of Florida. You can see on this slide a compilation of other data, including the suicide versus the homicide rate per county in each of the counties of the state. The department houses the statewide Office of Suicide Prevention and hosts the Suicide Prevention Coordinating Council. Goals of the statewide Office of Suicide Prevention are to implement the Florida Suicide Prevention Strategy, to provide oversight, to build capacity and create policy, and to mobilize communities to reduce the number of suicides and to improve the quality of life for all Floridians. Note that the Florida Suicide Prevention Strategy is consistent with the National Strategy for Suicide Prevention. Even if one's suicidal thoughts and feelings have subsided, get help for them. Experiencing that sort of emotional pain is itself a traumatizing experience. Finding a support group or a therapist can be very helpful in decreasing the chances that the person will feel suicidal again in the near future. You can help and get referrals from their doctor or from the organizations that I've listed in this module. There's 5 steps that are suggested to recovering from suicidal thoughts and feelings. They include identify triggers or situations that led to the feelings of despair or generated suicidal thoughts, such as an anniversary of a loss, alcohol, or stress from relationships. Find ways to avoid these places, people, or situations. Take care. The individual should take care of themselves, eat right, Don't skip meals and get plenty of sleep. Exercise is also a key because it releases those endorphins and relieves stress and promotes emotional well-being. Build a supportive network. The individual should surround themselves with positive influences and people that make them feel good about themselves. The more invested someone is in others and in their community, the more they have to lose, which will help them to stay positive and on the recovery track. Develop new activities and interests. Find new hobbies, volunteer activities, or work that gives that person a sense of meaning and purpose. When we're doing something that we find fulfilling, we feel better about ourselves, and feelings of despair are less likely to return. Learn to deal with stress in a healthy way. The individual should find healthy ways to keep stress levels in check, including the exercise I mentioned, or meditation, or using sensory strategies to relax, practicing simple breathing exercises, and challenging self-defeating thoughts. If you believe that someone is at risk of suicide, ask them if they are thinking about killing themselves. This will not put the idea into their heads or make it more likely that they will attempt suicide. Call the U.S. National Suicide Prevention Lifeline at 1-800-273-TALK. Take the person to an emergency room or seek help from a medical or mental health professional. Be sure and remove any objects that could be used in a suicide attempt, and if possible, do not leave that person alone.
If you think someone is suicidal, don't be afraid to confront them and ask the question. One way of asking them the question is like this. Others in similar circumstances have thought about ending their life. Have you had these thoughts? Confronting the person head on may just save their life and be a turning point for them.
This concludes the content section for Module 2 and for this course on suicide prevention. Do you know what is included in a suicide risk assessment? How about the environmental factors to consider? Can you describe the protective factors that may play a role in reducing suicide risk? How about identification of what should be included in a safety plan? Do you know what should be said and done if someone threatens suicide? What resources are there in the state and nationally that can assist in prevention and recovery from suicide attempt? If you're comfortable with answering these questions, then go ahead and take the knowledge review. Otherwise, go back and review Module 2 again. To complete the knowledge review, go back to the M2 tab and click open the Module 2 Knowledge Review. After completing the knowledge review, you may decide that you need additional study of this information. If so, go back to the beginning of this module. If you correctly answer 16 out of the 20 questions on the knowledge review, you may choose to go on to the course exam. Take the required survey and then move ahead to the pre-certification section to complete the process for obtaining your certificate for this course.